Dear listeners, this video is part 4 in this 4-part series on ischemic heart disease. For other videos in this series, see Prescribon Medical Education series, Ischemic Heart Disease. Stable angina pectoris. This episodic clinical syndrome is due to transient myocardial ischemia. The typical patient with angina is a man above 50 years or a woman above 60 years of age who complains of episodes of chest discomfort, usually described as heaviness, pressure, squeezing, smothering, or choking, and only rarely as frank pain. When the patient is asked to localize the sensation, he or she typically places a hand over the sternum, sometimes with a clenched fist, to indicate a squeezing central substernal discomfort. Angina is usually crescendo-decrescendo in nature, typically lasts 2 to 5 minutes, and can radiate to either shoulder and to both arms, especially the ulnar, that is inner surfaces of the forearm and hand. It also can arise in or radiate to the back, interscapular region, that is the area between the shoulder blades, root of the neck, jaw, teeth, and epigastrium. Angina is rarely localized below the umbilicus or above the mandible. Although episodes of angina typically are caused by exertion, that is, example exercise, hurrying, or sexual activity, or emotion, example stress, anger, fright, or frustration, and are relieved by rest. They also may occur at rest and while the patient is recumbent. The patient may be awakened at night by typical chest discomfort and dyspnea. Conscious respiratory effort is called dyspnea. The threshold for the development of angina pectoris may vary by time of day and emotional state. Many patients report a fixed threshold for angina, which occurs predictably at a certain level of activity, such as climbing 2 flights of stairs at a normal pace. In these patients, coronary stenosis and myocardial oxygen supply are fixed, and ischemia is precipitated by an increase in myocardial oxygen demand. They are said to have stable exertional angina. In other patients, the threshold for angina may vary considerably within any particular day and from day to day. In such patients, variations in myocardial oxygen supply, most likely due to changes in coronary vasomotor tone, may play an important role in defining the pattern of angina. Exertional angina typically is relieved in 1 to 5 minutes by slowing or cessation of activities, and even more rapidly by rest and sublingual nitroglycerin. Indeed, the diagnosis of angina should be suspect if it does not respond to the combination of these measures. Dear listeners, by the way, this educational video is made possible by Prescribon, the makers of e-prescription software for digital prescriptions available freely for doctors on the website www.prescribon.com. Doctors who are interested in this e-prescription can freely avail of its vast collection of more than 100,000 e-prescriptions. ST elevation myocardial infarct, STEMI. A transmural infarct is sometimes referred to as an ST elevation myocardial infarct, that is STEMI. Non-ST elevation myocardial infarct, NSTEMI. A subendocardial infarct is referred to as a non-ST elevation infarct. Laboratory evaluation. The laboratory evaluation of myocardial infarction is based on measuring the blood levels of proteins that leak out of irreversibly damaged myocytes. Previously, this involved measurement of the MB fraction of creatinine kinase, CKMB. Currently, the most clinically useful biomarkers of myocardial damage are cardiac specific troponins T and I, CTNT and CTNI, proteins that normally regulate calcium-mediated contraction of cardiac muscle. The diagnosis of myocardial injury is established when blood levels of troponin are elevated above threshold levels. Cardiac troponins begin to rise in 2 to 4 hours and peak at 24 to 48 hours after an acute infarct. Significant acute elevation in serum protein troponin can also be seen in other conditions that cause death of cardiac myocytes such as myocarditis and myocardial trauma. Recommended initial therapies for acute myocardial infarction include the following: oxygen supplementation to improve blood oxygen saturation for patients with hypoxia or respiratory distress, nitrates to induce vasodilation and reverse vasospasm, antiplatelet agents such as aspirin, ADP receptor inhibitors, and GP2B3A inhibitors, anticoagulant therapy with unfractionated heparin, low molecular weight heparin, direct thrombin inhibitors, and or factor 10A inhibitors to prevent coronary artery thrombus propagation, prompt reperfusion to salvage myocardium by either fibrinolytic medications or transcatheter interventions, improve myocardial oxygen supply versus demand by management of other factors such as anxiety, ischemic pain, abnormal hemodynamics, anemia, and respiratory disorders. Early arrhythmia monitoring and management. Consequences and complications of myocardial infarction. Extraordinary progress has been made in improving patient outcomes after acute myocardial infarction. The overall in-hospital death rate for myocardial infarction is approximately 7 to 8%, with STEMI patients experiencing slightly higher mortality 10% than NSTEMI patients, that is 6%. Unfortunately, mortality for out-of-hospital MIs is substantially worse. 1/3 of patients who are unfortunate enough to suffer a STEMI at home will die, usually of an arrhythmia within 1 hour of symptom onset and before they can receive medical attention. Such statistics make the rising rate of coronary artery disease in countries with limited hospital facilities all the more worrisome. Nearly 3/4 of patients experience one or more of the following complications after an acute myocardial infarction. Contractile dysfunction. In general, MIs affect left ventricular pump function in proportion to the volume of damage. In most cases, there is some degree of left ventricular failure manifested as hypotension, pulmonary congestion, and pulmonary edema. Severe pump failure, that is cardiogenic shock, occurs in roughly 10% of patients with transmural myocardial infarctions and typically is associated with infarcts that damage 40% or more of the left ventricle. Papillary muscle dysfunction. Although papillary muscles rupture infrequently after myocardial infarction, they often are dysfunctional and can be poorly contractile as a result of ischemia, leading to post-infarct mitral regurgitation. Much later, papillary muscle fibrosis and shortening or global ventricular dilation also can cause mitral regurgitation. Right ventricular infarction. Although isolated right ventricular infarction occurs in only 1 to 3% of myocardial infarctions, the right ventricle is affected by right coronary artery occlusions, leading to posterior septal or left ventricular infarction. In either case, right-sided heart failure is a common outcome, leading to pooling of blood in the venous circulation and systemic hypotension. Myocardial rupture. Rupture complicates only 1 to 5% of myocardial infarctions, but is frequently fatal when it occurs. Left ventricular free wall rupture is most common, usually resulting in rapidly fatal hemopericardium and cardiac tamponade. Ventricular septal rupture creates a ventricular septal defect with left to right shunting. Papillary muscle rupture leads to severe mitral regurgitation. Rupture occurs most commonly within 3 to 7 days after infarction. Arrhythmias. Myocardial infarctions lead to myocardial irritability and conduction disturbances that can cause sudden death. Approximately 90% of patients develop some form of rhythm disturbance, with the incidence being higher in STEMIs versus NSTEMIs. Myocardial infarction associated arrhythmias include heart block of variable degree, including asystole, bradycardia, supraventricular tachyarrhythmias, ventricular premature contractions, or ventricular tachycardia, and ventricular fibrillation. The risk for serious arrhythmias, example ventricular fibrillation, is greatest in the first hour and declines thereafter. Pericarditis. Transmural myocardial infarctions can elicit a fibrinohemorrhagic pericarditis. This is an epicardial manifestation of the underlying myocardial inflammation. Chamber dilation. Because of the weakening of necrotic muscle, there may be disproportionate stretching, thinning, and dilation of the infarcted region. Mural thrombus. With any infarct, the combination of attenuated myocardial contractility causing stasis, chamber dilation, and endocardial damage can foster mural thrombosis, potentially leading to left-sided thromboembolism. Non-infarcted myocardium. The non-infarcted segments of the ventricle undergo hypertrophy and dilation. Collectively, these changes are termed ventricular remodeling. The compensatory hypertrophy of non-infarcted myocardium is initially hemodynamically beneficial. However, this adaptive effect may be overwhelmed by ventricular dilation with or without ventricular aneurysm and increased oxygen demand, which can exacerbate ischemia and depress cardiac function. There may also be changes in ventricular shape and stiffening of the ventricle due to scar formation and hypertrophy that further diminish cardiac output. Prognosis, that is long-term outlook after myocardial infarction. Long-term prognosis after myocardial infarction depends on many factors, the most important of which are the residual left ventricular function and the extent of any vascular obstructions in vessels that perfuse the remaining viable myocardium. The overall total mortality within the first year can be as high as 30%. Thereafter, each passing year is associated with an additional 3 to 4% mortality among survivors. Infarct prevention through control of risk factors in individuals who have never experienced myocardial infarction, that is primary prevention, and prevention of reinfarction in MI survivors, that is secondary prevention, are important strategies that have received much attention and achieved considerable success. Prevention, explanation and reassurance. Patients with ischemic heart disease need to understand their condition and realize that a long and productive life is possible even though they have angina pectoris or have experienced and recovered from an acute myocardial infarction. A planned program of rehabilitation can encourage patients to lose weight, improve exercise tolerance, and control risk factors with more confidence. Identification and treatment of aggravating conditions. A number of conditions may increase oxygen demand or decrease oxygen supply to the myocardium and may precipitate or exacerbate angina in patients with ischemic heart disease. Obesity, hypertension, and hyperthyroidism should be treated aggressively to reduce the frequency and severity of anginal episodes. Adaptation of activity. Myocardial ischemia is caused by a discrepancy between the demand of the heart muscle for oxygen and the ability of the coronary circulation to meet that demand. Most patients can be helped to understand this concept and utilize it in the rational programming of activity. Many tasks that ordinarily evoke angina may be accomplished without symptoms simply by reducing the speed at which they are performed. Patients must appreciate the diurnal, that is, variation of severity during different times of day, diurnal variation in their tolerance of certain activities, and should reduce their energy requirements. In the morning, immediately after meals, and in cold or inclement weather. On occasion, it may be necessary to recommend a change in employment or residence to avoid physical stress. Physical conditioning usually improves the exercise tolerance of patients with angina and has substantial psychological benefits. A regular program of isotonic exercise that is within the limits of the individual patient threshold for the development of angina pectoris and that does not exceed 80% of the heart rate associated with ischemia on exercise testing should be strongly encouraged. Treatment of risk factors. A family history of premature ischemic heart disease is an important indicator of increased risk and should trigger a search for treatable risk factors such as hyperlipidemia, hypertension, and diabetes mellitus. Obesity impairs the treatment of other risk factors and increases the risk for adverse coronary events. In addition, obesity often is accompanied by three other risk factors: diabetes mellitus, hypertension, and hyperlipidemia. The treatment of obesity and these accompanying risk factors is an important component of any management plan. A diet low in saturated and trans unsaturated fatty acids and a reduced caloric intake to achieve optimal body weight are a cornerstone in the management of chronic ischemic heart disease. It is especially important to emphasize weight loss and regular exercise in patients with the metabolic syndrome or overt diabetes mellitus. Cigarette smoking accelerates coronary atherosclerosis in both sexes and at all ages and increases the risk of thrombosis, plaque instability, myocardial infarction, and death. In addition, by increasing myocardial oxygen needs and reducing oxygen supply, it aggravates angina. Hypertension is associated with an increased risk of adverse clinical events from coronary atherosclerosis as well as stroke. In addition, the left ventricular hypertrophy that results from sustained hypertension aggravates ischemia. There is evidence that long-term effective treatment of hypertension can decrease the occurrence of adverse coronary events. Diabetes mellitus accelerates coronary and peripheral atherosclerosis and is frequently associated with dyslipidemias and increases the risk of angina, myocardial infarction, and sudden coronary death. Aggressive control of the lipidemia. Target LDL cholesterol should be below 70 mg per deciliter and hypertension, target blood pressure 120 by 80 millimeters that are frequently found in diabetic patients is highly effective and therefore essential. Dyslipidemia. The treatment of dyslipidemia is central in aiming for long-term relief from angina, reduced need for revascularization, and reduction in myocardial infarction and death. The control of lipids can be achieved by the combination of a diet low in saturated and trans unsaturated fatty acids, exercise, and weight loss. Nearly always, HMG coenzyme A reductase inhibitors called statins are required and can lower LDL cholesterol about 25 to 50%, raise HDL cholesterol 5 to 9%, and lower triglycerides 5 to 30%. A powerful treatment effect of statins on atherosclerosis, ischemic heart disease, and outcomes is seen regardless of the pre-treatment LDL cholesterol level. Fibrates or niacin can be used to raise HDL cholesterol and lower triglycerides. However, compliance with the health-promoting behaviors listed above is generally very poor. Major effort by the patient is required to meet the challenge of obeying all the above restrictions. Takeaways of this video series. The heart is so specialized that it gets only very brief intervals of rest, almost always destined to work, from birth to death. No lunch intervals, no day offs, no Sundays, and no holidays. Unfortunately, even when it gets injured, and even while healing after injury, which takes some time, it is expected to work with normal efficiency, which, alas, it is not practically possible. Apart from its muscle, its electrochemical circuitry is so sophisticated and intertwined with its pumping muscle that whenever the heart muscle is damaged, there is a good possibility of its electrochemical circuitry also liable to go awry and behaves strangely so that life itself can be in danger. Just be aware that even though you have so many organs which are in twos, you have only one heart, ONE1. So, dear viewers, you are given a healthy heart and be kind to it. Prevent it from getting into trouble as much as possible. Your heart will be so grateful for your kindness and will work dedicatedly till your destined time on this earth. To prevent it from getting into trouble, do the following. Do not eat too much. Keep your stomach half full only. Understand that your body needs very little simple foods. Eat slowly. Major meals should last at least 15 minutes. Cut out calorie-rich, fatty or oily foods or use them very sparingly. Exercise as part of your daily routine. Simple exercises for 2 minutes every half an hour whenever privacy permits. No alcohol, no tobacco, no drugs except those prescribed by your doctor. All this make your heart say thanks for your kindness. Dear listeners, this is the end of discussion on ischemic heart disease. See Prescribon Medical Education series for videos on other topics. Thank you for viewing this video.